Wednesday morning, and it's time for the weekly ward round. Doctors, medical students and researchers gather to discuss the treatment for different patients. Chris Wells is the research director of the clinic.
How are you getting on?
Oh, not so bad, thanks.
Tell us about your pain. Just tell us in your own words what it's like.
Oh, well, it's terrible when it's, it is bad.
Right. But where is it,
Here,
first of all?
in the bottom, it's in the bottom.
Okay.
Jaw.
And how long have you had it for altogether?
Oh, I've had it quite a number of years. It would come and then it would...
We're a very long-established clinic, and we've been able to develop a lot of different techniques for pain relief. And perhaps one of the most important things about the unit is that we have a group of doctors and scientists from different disciplines who can look at the various aspects of pain and therefore the many different treatments that are available.
Well, not everybody, but you seem to, so that's the important thing.
Yes, no problem at all.
Incredible, incredible. What else starts it off?
If I, when you wash, I just have to pat. I cannot.
Yes, can't rub it. Chronic pain in most patients is made up of several different factors. There may be physical input, there may be muscle spasm on top of that. The person may have lost their self-confidence and become depressed. And we may need to look at all those different things and treat each aspect. And when that pain first came, was it just a pain that was caused by touch, or was it there every minute?
No, it was all the time. It started like...
unusual for trying
It started like it's a jump, and then I get a burning sensation.
And you're doing a nice
face.
picture of the band which is coming down the jawbone.
Down there.
But also just above
right across my top
the right
lip, and
lip.
it stopped there.
Yeah.
But how do people experience pain in the first place? For a long time, there was thought to be a specific pain-detecting system in the body that transmitted messages to a centre in the brain. This was based on ideas put forward by the philosopher Descartes as early as the 16th century. According to the theory, a stimulus, such as a fire, is detected by special receptors. The message is transmitted along a pathway within the body and eventually reaches the brain, where something like an alarm bell goes off. We now have a better idea of what this pathway looks like in anatomical terms. We know, for instance, that in the skin there are receptors that are capable of responding to stimuli such as touch. But there are also receptors that respond to noxious stimuli, such as heat or extreme pressure. These nerve endings are called nociceptors. Damage to the skin will activate these receptors and initiate the transmission of nerve impulses or action potentials along sensory neurons. The signals are passed into the spinal cord and then up to the brain. According to the model, the relief of pain would essentially involve interrupting this pathway somewhere between the site of the stimulus and the brain. Take familiar pain-relieving drugs like aspirin. Once absorbed into the bloodstream, these act at the site of injury, blocking the release of chemicals such as prostaglandins that cause the firing of the nociceptors. Fewer impulses are initiated, and so there's less pain. If impulses are initiated, a second approach is to block their transmission along the sensory neurons, say by local anesthetics. Finally, it's possible to prevent impulses reaching the brain by other means. Any activated pathway from a site of injury to the brain can be selectively destroyed, say by surgery. Thursday morning at the operating theatre. A woman from yesterday's ward round is about to undergo treatment for a severe form of facial pain called trigeminal neuralgia. The facial pain she suffers isn't due to any physical damage to her skin or muscles. It's the result of an abnormal pattern of firing in her trigeminal nerve, which delivers sensory information from her face. There are 3 parts to the nerve. One supplies the lower jaw, the second supplies the cheek, and the third supplies the eye and the upper part of the skull. It's usually only one of the three parts that's affected in trigeminal neuralgia. The aim of the operation is to insert a needle containing an electrode into a selected part of the nerve and destroy it by heat treatment. The insertion is done under anaesthetic.
Putting the needle in the plane of the TM joint.
X-rays are used to monitor the position of the needle.
There we are.
There's a TMJ here, isn't
That's it there. And now come out immediately.
The needle is carefully pushed through the skin and muscles until it reaches a hole in the skull where the trigeminal nerve is located. It's possible to test that the electrode is properly positioned by passing a small electric current through the needle. The patient should feel a sensation in the appropriate part of the face.
With 3.
Yes.
Off. Did you feel something in your face?
Yes.
Okay. Now, does that come along here?
Yes.
Does it come over here?
Yes.
Good. All right.
Once the electrode is in place, it's heated slowly to about 70 degrees centigrade. Just enough heat is supplied to destroy the affected part of the nerve. So how successful is the operation? Next day at the ward.
Well, good morning, first of all.
Morning.
How are you today?
I'm very well, thank you.
How's
Wonderful.
the face feeling?
Oh, it's all right. Numb, but...
Yeah, it's numb in this part of the jaw.
Yes, yes.
And what
but-
about in the cheek?
Not really, but it is numb up
Up
to my
there,
ear.
right.
Yes, there.
So that's
yes.
in a band coming down.
like
that.
yes,
Great,
yes,
okay.
That's it, yes.
I'm just going to check this out with this little pin to see what you feel like.
Yeah,
So that's good. What's that like?
a bit sharpish.
Bit
well,
sharp.
red.
What about there?
Nothing at all.
And there?
Yes,
That's sharp.
sharp. Yes,
And that side?
yes, a bit. Not very sharp. That's sharp. Yes, nothing at all.
Okay. And what's your tongue feel like?
Yes, that's a bit numb.
It's a bit numb as well.
yes.
Can you just pop that out for us? And now I'm going to touch the...
There.
That's sharp.
Mm-hmm. Nothing at all.
And nothing on that side.
No.
Okay. Right.
No.
So this form of treatment, specifically blocking part of a nerve pathway, does work for these forms of localized pain. Some other nerves may also be destroyed, causing numbness, but the pain has gone. And the proof of the pudding is in the eating.
How are you getting on?
It was lovely to eat toast this morning.
Right.
And Kellogg's, crisp Kellogg's.
Right, okay. You have to be very careful when you're eating, not to chew the inside of your mouth on the right side. You'll get used to that over a period of weeks, and that'll become a second nature to you. Just at the moment, you might catch the inside of the mouth. And after a time, that won't be a problem. And your pain won't be a problem.
Thank goodness.
So you'll be able to go on laughing,
Laughing.
and eating toast, and doing all the things that normal people have always been able to do without thinking about. And you've actually not been able to do them.
To do. Have sweets. Bite an apple.
Toffees, yes.
But there are puzzles that can't be explained by our simple model of pain. Why isn't there a clear relationship between our perception of pain and the extent of injury? For instance, nearly half of the people who turn up at hospital casualty departments may report that they didn't feel any pain until many minutes or even hours after the injury. On the other hand, in many cases of pain, there's no evidence of physical damage to the tissues. There is pain, but no apparent injury. In the 1960s, Professor Patrick Wall and his colleagues developed a theory of pain perception that attempted to explain these puzzles. Remember that sensory neurons carry messages from tissues like the skin into the spinal cord. The sensory information enters the spinal cord along nerve bundles called the dorsal roots, each containing many thousands of nerve fibers of different sizes. Some of the larger diameter or thick fibers conduct information from touch-sensitive receptors in the skin, whereas the small diameter or thin fibers respond to noxious stimuli. A new element in the theory was that on its path from the spinal cord to the brain, the pattern of nerve impulses can be modified. But how? Looking at a cross-section of the spinal cord, we see that the thin sensory fibres transmitting information about tissue damage end up in a region known as the dorsal horn. The impulses are delivered from the thin fibres to special cells called T cells, since they transmit the incoming message to the brain. According to the theory, there are intervening neurons that can influence the transmission of impulses from the sensory fibres to the T cells. In effect, these act as a gate. When there's no input from the intervening neurons, the gate is open. The thin sensory fibres are able to excite the T cells, and pain may result. When there is input from the intervening neurons, the gate is closed. Signals in the thin sensory fibres can't excite the T cells, so no message gets relayed and no pain is perceived. The gate can also be influenced by the pattern of activity in other nerve fibres that enter the spinal cord. For instance, the thick sensory fibres that transmit information about touch. Impulses from the thick fibres can affect the intervening neurons and effectively close the gate. In other words, simple rubbing, scratching or massage can actually relieve pain by generating impulses that compete with those arising from an injury. Touch signals close the gate by acting as a counter-irritant.
And what do you feel down in the hand?
Feels like it's gone cold, numb.
Yes, going cold and numb.
Yeah.
Now that, you see, if you had pain in the hand, this would be a very good test of whether rubbing the nerve or any kind of counter-irritation is going to relieve the pain. But you don't have pain in the hand. You've got it.
Can we go one step further and stimulate sensory nerves, not mechanically, but electrically?
So this is an electrical stimulator. These are the pads with some gel on them to conduct the electricity, to avoid burning of the skin. What we're going to do is to put those two pads on your neck, and then we're going to control the current by these knobs here, in particular switching on until you feel this gentle tingling sensation. And that's what we're looking for. And we'll want to leave that on then for 20 minutes, half an hour, and see whether it does anything for your pain. Many patients, when they come to us, are desperate and say nothing affects their pain. But in fact, when you analyze it, you find that many different things can affect pain. And if, for instance, rubbing or heat or any of these, what might loosely be labeled as counter-irritants, relieve a patient's pain, then there is a good chance that electrical stimulation, acting as it does, I believe, simply as a controlled counter-irritant, will subsequently relieve their pain. Here we go again. Tell me when you feel it. Now, do you get any pain in that position?
Yes.
Right. Now, what does this feel like?
It wasn't.
Is it painful?
No, it's not painful.
Can you feel your own pain in that area?
No.
No. Well, that's what we're looking for, you see. We're looking for the buzzing sort of interfering or masking or even replacing the pain that you've got. So I think with you, what we're going to do is to try the stimulation on the one side first, rather than trying to cover the whole area. And then when you've got some confidence...
So much for therapies based on stimulating sensory neurons. What about other ways of shutting the gate? The 1956 FA Cup final. 15 minutes before the end of the match, another drama.
There's Brown. And I think Trotman's hurt. Yes, and so's Murphy. Looks like Murphy's knee and Trotman's head. Well, now, it's obviously not his head, but his neck. Now, this is the neck that Trotman hurt 2 years ago, 2 weeks ago rather, and he had to have quite a lot of manipulative treatment to get the neck back in place, and it could well be serious for Manchester if that neck's been knocked out of joint again.
Goalkeeper Bert Trautmann injured his neck but continued to play in the match even after the accident. It's clear that in situations like this, excitement and the events of the moment allowed him to shift attention away from his pain.
Quarter of an hour from the end in an FA Cup final to have your goalkeeper worried by...
What's the mechanism for this type of pain suppression? Let's return to the gait control model. According to the theory, the setting of the gait is controlled by the pattern of neural activity entering the spinal cord from both the thick and thin sensory fibres. But it's also affected by powerful influences descending from the brain. What's the chemical basis for this? The clue is as old as folk medicine itself. Opium, the extract from poppy seeds, has long been known to have a pain-relieving effect. The Greeks called it morphine, after Morpheus, the god of dreams. The pain-relieving effects of morphine are due to action at two main sites, one in the dorsal region of the spinal cord, and the other in the brain, particularly in the brainstem. In these areas, there are special receptors that can recognize and bind to morphine and its related compounds, rather as a lock accepts a key. This interaction sets in train mechanisms that allow morphine to close the gate by depressing the activity of the T cells that relay pain messages to the brain. But why should there be receptors in the body for a drug like morphine? It turns out that the body manufactures its own chemicals called endorphins, which have the same action as morphine. Several families of chemicals related to these have now been discovered. For example, the enkephalins and the dynorphins. These are an important factor in suppressing pain during times of acute stress. But for some sufferers, there's no obvious form of therapy. It's in situations like this that the Pain Relief Clinic has developed a special program to help them manage and cope with their pain. The principle of the program is based on a psychological approach to pain treatment. Eric Gadiali is the chief psychologist at the program.
What we're trying to do on the program here is help you cope better with pain. Generally speaking, the way we think people cope better with pain is by doing as much as you can, by being mentally and physically active.
The program includes physiotherapy, exercise, relaxation techniques, such as meditation and even faith healing and group counselling. Even if each method has only a limited effect, the combination of different approaches can be very beneficial.
When I was fit, they'd have been nothing to me at all. And in some ways it can be quite upsetting to sort of struggle doing very basic exercises. But if I can master those, then it'll do me a lot of good, mentally as well as physically.
It's so relaxing. It's one of the first times in a long time that the pain seemed to slow down. And it wasn't as strong.
The relaxation and the exercise are wonderful. They are really great. It kind of does make you more relaxed at home as well. And this is definitely a bonus.
Okay, don't expect too much. You all know your own limitations, but you also know your own capabilities. So don't be fooling yourselves and setting targets which are really a little bit too easy. You do have to push a bit, but don't go over the top. How far did you swim last time you went to baths?
Probably a little bit too.
An important aspect of the program is the group therapy. People can share their experience of pain with others in an atmosphere of mutual support and encouragement. Combined with expert counselling, this gives sufferers a more confident and more realistic approach to coping with pain.
How do you feel about that? Okay. Yeah.
Well,
Generally speaking, people report that they're able to do more at the end of the program. Very often they may be going back to work, or they're doing more things at home, taking more interest in life. They've learnt to understand the psychological aspects of their pain, and not just understand it, but use them positively. If you actually look at the pain itself, very often that's unchanged, or if it is changed, it just decreases a little bit. And that emphasises what the programme is all about. It's not a programme designed to treat pain in the way an injection or a tablet is designed to treat pain. What we're trying to do is help people to cope better with pain.
I'm not looking for a miracle, but I feel good going there. You can talk to people, and you feel something better in your mind. Oh, it's very good. It's very good to have people there who understand what is pain and to cope with it.
Turning your feet and don't stretch your body over, keeping your spine straight. Just push. Lovely. Now don't forget to bend your feet. Only bend.